So this is the study setting, the study setup. It's a nationwide cohort study. We include all children born in Denmark from 2009 to 2016.
Sorry, Professor Reed, would you be able to get a little closer to the microphone?
No, I'm as close as I can get, I think.
Okay, thank you. If you could just speak louder, we'd appreciate it. We want to hear your talk. Thank you.
Okay. So all children born from 2009 to 2016. We started the follow-up in the study in 2011, 1st of January, and ended it on the end of 2018. And similar to Dr. Daly's study, we looked at, we had follow-up from 2 to 5 years of age. And it's important for you to understand that all our exposure and outcome data are from nationwide registers that cover the complete population, and that we have easily and free universal healthcare in Denmark. And the study's cohort size that we operate with here is 470,000 children. Next slide, please. So this is a little about the Danish childhood vaccination schedule. It's not as extensive as many other countries. In the first year of life, we have the infant vaccines at 3, 5, and 12 months. That's a diphtheria, tetanus, pertussis, inactivated polio, hip shot, and a separate pneumococcal shot. 3 doses. Then at 15 months, we have MMR1 at 4 years, MMR2, and then a booster at 5 years, and then HPV at 12 years. And below you can see the aluminum content in the vaccines that we're using during the study period. And so for the DTP shot, for the majority of the study period, we used a formulation here from SSI, which had 1 microgram of aluminum hydroxide per shot. This was then changed in 2019 to Pentavac, which has only a third of that aluminum content. However, we did have some production and supply issues intermittently in the study period, and that's why we're also seeing that we've used infant Rixhexa and Hexion when that was the case throughout the study period. They also have an hepatitis B part, and they have a little bit less aluminum content than the shot that we used most of the time. And then we've used Prevnar 7 and 13. You can see that the aluminum content for those shots also. Next slide, please. So here you can see the cumulative aluminum exposure that we are talking about in our study here. To your left, we have the box plots of cumulative aluminum content received through vaccines by age 2. All the numbers here are in micrograms. And from the box plots, you can see that the majority of the variation in our data, in our study here, is basically across birth cohorts. Within each birth cohort, you don't see a lot of variation. For example, in 2011, 10, 11, and 12, you can see that the percentiles overlap completely, which basically means that for 50% of the, at least for 50% of the children, they had the exact same aluminum exposure, is the same as the medium. And at your right, you can see the actual numbers. And if to contextualize it a little bit to the US situation, for the birth year 2009, the median was 4.125 micrograms of aluminum by 2 years of age. And I think that's more or less the same as Dr. Daly had in his whole study, that median value. But as you can see in the later birth year, the exposure is almost half by the end there in 2016. Next slide, please. So how did we define the asthma outcome? We included, similar to Dr. Daly, both hospital diagnoses and prescriptions. For hospital contacts, we used ICD-10 codes, J45, J46, asthma and status asthmatic was really severe asthma. We looked at both in and outpatient contacts. For prescriptions, we actually used a Danish validation study who looked at the positive predictive value and sensitivity of using different definitions of prescription use. And so we tried to balance towards having a high positive predictive value. And there we used inhaled corticosteroids, at least 2 prescriptions in the study period, short-acting beta agonist, at least 3, Montelukast, at least 2, and long-acting beta agonist, just 1 prescription. And for each of these criteria, that was enough to be classified as an asthma case in this study. We excluded everyone who had prescriptions or hospitalizations before study started at the age of 2. And then we used survival analysis, so analyzing the time to the first of the above events. Next slide, please. So these are our secondary outcomes we looked at. And this was sort of a data-driven approach, recognizing, as I just described, that we have different criteria for becoming an asthma case in our study. And also recognizing that these criteria are, of course, not mutually exclusive. So an asthma case could fulfill several of these criteria. And so this is just a data-driven cluster analysis, trying to sort of make some computational phenotypes of asthma in our study, some subcategories to dig a little bit deeper into in sub-analysis. And we found four clusters. The largest cluster, cluster 4, was primarily defined by the inhaled corticosteroids criteria, and for many also short-acting beta agonists. The second largest was more or less primarily defined by the short-acting beta agonist prescription criteria, and then we had 2 smaller clusters defined by hospitalization contacts and Montelukast. Next slide, please. So these are the descriptives for the cohort. As I mentioned, it was about 470,000 children. The column to your right, you can see sort of the overall descriptives for the cohort. First, according to birth year, you can see that, each birth year is approximately 60,000 plus or minus in Denmark. With respect to sex, slightly more boys than girls in our cohort. With respect to MMR vaccination status by 2 years of age, 86% had received their first MMR shot. And with respect to ethnicity, evaluated as the birth or the country of origin of the mother, 89% were born in Denmark of the mothers. All the children in our cohort were born themselves in Denmark. The other columns are categories of aluminum received through vaccines by the age of 2. You could say sort of the main takeaway here is if you look at the topmost row, the 0 micrograms of aluminum, these are the completely unvaccinated. So having not received any of the 6 shots in infancy that contains aluminum, we have very few of those, which is to be expected. Other than that, you can see that the different categories of aluminum received, they correlate quite strongly with the birth year. And that was sort of also what you could see when I showed you the box plots of aluminum exposure in our cohort by birth year. Next slide, please. And so these are our main results. The primary outcome, which was hospitalization contacts with asthma diagnosis or any of the different anti-asthma medication criteria. We had approximately 5,800 asthma cases using this definition. You can see here the hazard ratios of getting or fulfilling our asthma criteria throughout the follow-up according to aluminum received through vaccines by the age of 2. Here the reference category is the lowest category, but among those who received aluminum-containing vaccines. So less than 2.25 micrograms, but not completely unvaccinated. These are the ones with 0 micrograms. And what you can basically see is there's really no support for an association between aluminum received through the vaccines and development of asthma in this primary analysis. And these results are adjusted for sex, year of birth, maternal country of origin, and MMR vaccination status by age 2. Next slide, please. Here, it's a dose response analysis done in each birth year cohort. The dose response is per 1 microgram additional aluminum received through vaccines by the age of 2, and it's the primary asthma outcome. And again, as you can see, there is none of the birth cohorts is there really any strong support for an association between increasing amounts of aluminum received and the development of asthma defined using the primary outcome definition. Next slide, please. This is just then looking at the secondary outcome definitions from the data-driven cluster analysis I showed you. Here, I'm showing a comparison between the largest category of cumulative aluminum received, which is more than 3.375 micrograms by 2 years of age, compared to the reference category that I mentioned before. We're still talking about hazard ratios, but now according to development of asthma defined according to the different criteria here. Again, there's really no support for an association between aluminum received through vaccines and any of these data-driven ways of defining subcategories of asthma in our study. Next slide, please. The limitations. Yeah, so limited variability in cumulative aluminum received is of course a limitation, and of course the variability that we have in our data is strongly correlated with year of birth, which is a limitation. Of course, as Dr. Daly also mentioned, we don't really know if it's true persistent asthma or if it's wheeze in the youngest children. Next slide, please. But the takeaway of these preliminary results are there's really no support for an association between aluminum content received in vaccines and development of asthma by 5 years of age in Denmark. Next slide, please. There is no next slide. Okay, that was the last one. Thank you.
Thank you so much, Professor Bede. So this set of presentations is now open for questions and discussion. Dr. Chen.
Dr. Daly, thank you so much for for walking us through all that complex information. I do have one question comment, and it might be just my naivete and understanding, but I think I understood that you are recognizing that viral-induced wheezing might represent some sort of confounding. And I guess what asthma brings to mind is my medical school teaching, so this might be wrong now, but RSV early on in life it might be associated with increased risk of asthma. We don't know why. It might be a host factor, And so the reason I bring that up is because was RSV incident medically attended visit or hospitalization looked at, or is that something that you're looking at in the future? Because that could also represent not just the risk for asthma, but also that opportunity for vaccination because they're being brought into a medical home. So that was my question.
Yeah, thanks, Dr. Chen. So there is a published definition of early severe bronchiolitis. That is bronchiolitis resulting in hospitalization within the first 12 months of life, and that is associated with subsequent risk of asthma, although we don't know kind of the directionality of that, meaning do kids who are asthma prone then just have that happen, or does that happen and then cause them increased risk of asthma? In either case, we examined that in this study as a covariate, and it was significantly associated with risk of asthma, but when included as a covariate, it didn't change the underlying findings of the study.
Dr. Fleming-Dutra, did you want to add anything?
If you would like me to. So again, this is Dr. Fleming-Dutra. I'm the co-lead of the maternal pediatric RSV work group. And I was just going to reference kind of in response to your second point, there has been a more recent observational study that was published, I believe, in the Lancet, the INSPIRE trial, that looked at the association of RSV infection in infancy and later childhood development of asthma. And it was a very well done observational study that actually showed not only is bronchiolitis and wheezing in early childhood associated with later childhood asthma, but infection, even in the absence of wheezing in infancy, is related to later life or later childhood development of asthma. It is an observational study, so causality cannot be established. But I will also add that the two products that you all are considering for prevention of RSV infection in infants or RSV disease in infants probably, we don't think will have a large impact on infection. And so if RSV infection is in that, we don't know, but if it's in the causal pathway to later life asthma development, the current products, nirsevimab and maternal vaccination, probably will not mitigate that risk. But a lot is to be known, and we don't know right now.
Thank you. Dr. Long?
In a placebo-controlled modivizumab study, which is a highly potent monoclonal antibody against RSV in the American Indian population that was published, showed us that the prevention of RSV did not alter the likelihood of persistent asthma. So I think that has been put to rest, except as a unmasker. If you're set up to have asthma, you may be more likely to wheeze with RSV, but RSV does not cause the proclivity for asthma. I think that's where we are right now.
Thank you. Ms. McNally.
Thank you. Dr. Daly, I assume that VSD allows you to screen for any children who would have renal conditions such that they would be excluded.
Ms. McNally, do you say renal conditions?
Yes. Any renal diseases?
So, yes, and I may need to get back to you on details of sort of specific concerns that you have. I mean, I think that in this study, it's a large cohort. However, kids with complex chronic conditions were excluded from the analyses, but that's a small percentage, and that's based on something called the pediatric medical complexity algorithm. So, yes, we can detect it. It probably wouldn't influence the study findings here. Are there specific renal diseases that you were inquiring about that could sort of influence whatever we observed here?
So just thinking about the fact that aluminum is excreted by the renal systems, that was really kind of at the crux of my question.
Yeah, no, thanks. Thanks for that additional context. I mean, I think, we need to recognize that aluminum has been used in vaccines for more than 80 years, and there are several different forms of aluminum, hydroxide and phosphate, and that they're important immunogens. They enhance the immune response. They're there explicitly because they make vaccines work better. But even so, there are things that are not known about exactly the sort of pharmacokinetics and biologic activity of aluminum used as an adjuvant. There are studies that show that after vaccination, serum aluminum levels don't change, hair aluminum levels don't change, but then that doesn't exactly tell you sort of how that relates to how aluminum is excreted from the kidneys. And there is some work that I'm not terribly familiar with around when aluminum is used in parenteral nutrition, so essentially it's IV nutrition, but that's in extraordinarily high doses compared to what is injected in vaccines, so I'm not sure that's really comparable. So, your comment is sort of just a reason for us to also acknowledge some things that we don't know about the metabolism of aluminum. But what we do know is that probably any sort of underlying renal disease doesn't influence the immunogenic effects of aluminum, and so probably is not explaining any association that we see here.
That's helpful. And
okay.
Just as a follow-up question, as a parent, I'm trying to think through this. What impact, if any, would infant formulas have in this sort of evaluation?
Yeah, thanks so much for that. So, Ms. McNally, what's interesting context here is that breast milk contains aluminum and infant formula contains aluminum. And so one of the questions that I have in all of this is, does the aluminum that's taken in by breast milk or by formula cause any immunologic effect? And I don't have an answer to that other than to say that the thought is that very little of that is absorbed. So we can think about it a couple different ways. Does it relate to the association that we saw? Possible, but unlikely if it's not absorbed. But do we need to know more about this as we pursue this hypothesis? Definitely yes. I might see if Dr. Buddy Creech is on and if there's anything that he would add, because we've talked a little bit about this over the past couple of years. Dr. Creech?
Yeah, this is Buddy. Thanks for that, Matt. I think this level of inquiry is exactly right. There are environmental exposures that may impact overall aluminum exposures. It's hard to understand how those are differential in some of the analyses that were done. And then I think we have to recognize that different aluminum adjuvants do have different pharmacokinetic and pharmacodynamic properties, right? So aluminum phosphate dissolves more rapidly than aluminum hydroxide. So while we don't know that the immunologic effects of different alum preps would be substantially different, we do know that the pharmacokinetic and dissolution characteristics, the charge on the surface of the molecules, the shape of the molecules, all of those may have an influence.
That's really helpful. And I just want to thank you for doing this work, because I think this is so important and truly does help improve vaccine confidence.
Thank you. May I ask a very specific question, which is actually looking at Professor Veed's data, and thank you very much for presenting. I think it's incredibly helpful to have a complementary data source, and that one that has, you have such beautiful data in Denmark. You have the full cohort and all of the full information, so it's really helpful to have that complementary view. But one of the things I noted was the secular trend in exposure. And so that made me wonder whether or not there were any differences in the VSD data, or whether the study design accounted for calendar year or any other secular or seasonal trends.
Yeah, thanks, Dr. Lee. So down in the fine print on both the primary analysis slide and the secondary analysis slide, these analyses were all adjusted for calendar year and calendar month. And so, adjusted for example, a baby born in March of 2013, it's the year plus the month. And that's a fine level of adjustment, but we felt like that was necessary because of risk of secular trends, including of viral respiratory infections that could influence risk of asthma. So, and the cohort was big enough that we could make that fine a degree of adjustment, and that adjustment did not change the underlying association that we observed.
Dr. Lair?
I'd like to second Ms. McNally's comment and say thank you. As a practitioner with a large vaccine-hesitant population, I often get questions about the risks, and now I have more data to comment and say that they actually are studying these. So I appreciate the CDC and you're moving forward with these studies. Thank you.
Thank you. Any additional questions? Dr. Paling.
I want to echo my thanks for your doing the study and being very deliberate in the process, and then also making sure that you share and explain what you do and do not understand. I also very much appreciate the future directions and do believe this session during the ACIP is particularly helpful, and hope that as more information becomes available, that can be included in the future. Thank you.
Thank you. Dr. Sanchez? No? Okay. I don't see any other hands raised, so I also just want to add my thanks for, number one, pursuing this work on behalf of the public. There is an association that I am concerned about in the moment. I'm also very intrigued by the findings from diabetes, that it looked protective. So it gives you a little bit of pause to say it definitely deserves further work. And again, really appreciate the investment and the time and the care that is spent with regard to ensuring that our vaccination program is as safe as possible for our entire childhood population. So thank you. And with that, I think we're going to take a 5-minute break. And thank you, Professor Veed, for presenting from Denmark, whatever time it is there. We really appreciate your time and your effort on this work as well. Thank you again. 5 minutes after the hour, we'll reconvene. Thank you, everyone. Welcome back to the ACIP meeting. It is our last session of the day, of a 3-day meeting. So thank you to everyone who stayed on for the marathon sessions over the past 2.5 days. I will hand it over to Dr. Matt Daly, who is chair of the COVID-19 Vaccines Work Group, who will be providing an introduction and overview of today's session.
Great, thanks so much, Dr. Lee. So I'll be presenting today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So to review what we discussed at the April 19th, 2023 ACIP meeting, that meeting was entirely focused on COVID-19. At that meeting, we had a number of COVID-19 vaccine program updates, including vaccine safety updates, vaccine effectiveness updates. And then at that meeting, we reviewed data for and work group considerations for updates to the vaccine policy, to the COVID-19 vaccine policy, including the following: the use of a single bivalent vaccine dose for most persons aged 6 years and over. And then we had additional discussion about how to use bivalent vaccines for children aged 6 months through 5 years. In addition, we discussed optional additional bivalent doses for persons 6 months and older who are moderately or severely immunocompromised, and then additional bivalent doses for use in adults aged 65 and over, and then discussed a clinical considerations update. Next slide, please. Since that April 19th meeting, here's some of the work that the ACIP COVID-19 Vaccines Work Group has been doing. We've looked at the epidemiology, the current epidemiology of COVID-19, including among specific groups, pregnant people and infants. And then we had a series of vaccine effectiveness updates. And then we had continued conversations about who are the populations who still need a primary series. And by that, we mean a multi-dose series as distinct from a single dose. Next slide, please. And then as everyone in the room and on the phone, I think, is probably well aware, on June 15th of 2023, FDA's Vaccines and Related Biologic Products Advisory Committee, or VRBPAC, met to discuss strain selection for updating COVID-19 vaccines, and came to the following conclusion: that based on the totality of the available evidence presented, the FDA advised manufacturers to develop an updated COVID-19 vaccine with a monovalent XBB.1.5 composition. And by monovalent, it's just focused on the XBB.1.5 and would not contain Wuhan strain. And then there was an anticipation that these updated vaccine doses would be broadly available in the fall, and that following updated vaccine authorizations by the FDA, then the ACIP would convene to review evidence to inform updated recommendations for the use of COVID-19 vaccines in the US population. Next slide, please. So here's the agenda for today. We're going to have updates to COVID-19 epidemiology and vaccine effectiveness by Dr. Havers, Dr. Galong, and Dr. Link Gellis from the CDC. After that, we'll hear about infection-induced and hybrid immunity from Dr. Jones at the CDC. And then after that, we'll hear from Dr. Wallace, who will review summary and work group considerations. Next slide, please. Just want to thank the ACIP COVID-19 Vaccines Work Group, including ACIP members, Dr. Bell, Dr. Lee, Dr. Talbot, and Dr. Brooks, ex officio and government members, liaisons, and consultants, and then the tremendous leadership of Doctors Megan Wallace and Sarah Oliver. Next slide, please. And then I'll turn it back to you. Thanks.
I'll turn it right over to Dr. Havers, Galong, and Link Gellis.
Great. Thank you very much for having me today. My name is Fiona Havers, and I'm the lead for the RESPNet, the RSVNet, and COVIDNet hospitalization surveillance team. I'm going to be talking today about recent epidemiology of COVID-19 associated hospitalizations, including in pregnant persons and infants. Next slide. So the data I'm going to be showing is going to be somewhat since the start of the pandemic, but really focusing on recent epidemiology. Next slide. So I'm not going to go into too much detail on this slide, as many of you are familiar with COVID-19, but it is a large population-based surveillance system that covers about 10% of the US population in 13 states with more than 250 acute care hospitals. To be a case in COVID-19, you have to have a positive SARS-CoV-2 test within 14 days of or during hospitalization. And these are identified generally based on clinician-driven screening on admission to the hospital or clinician-driven testing. However, we do have clinical data from a representative sample of COVID-19 patients, and we can sort those out by symptoms and reason for admission. Next slide. So here's an epi curve that many of you are familiar with. This is COVID-19 associated hospitalization rates since the beginning of the pandemic by age group. And as you can see, the data from the most recent months since January 2023 is highlighted in the insert on the right. Generally speaking, hospitalization rates have been relatively low in the last several months, and this data goes through the week ending June 3rd. Rates continue to be the highest in those who are 75 years and older, followed by those 65 to 74 years, and in infants less than 6 months. Those are the age groups that are shown in the blue lines, and I'm going to talk specifically about infants less than 6 months of age later on. Next slide. I also wanted to share data from COVID-19 and hospitalization rates by race and ethnicity. On the right-hand side is a weekly age-adjusted 3-week moving average rate from January through May to kind of highlight the most recent months. The orange lines are American Indian and Alaska Native populations, which continue to have the highest rates of hospitalizations, followed by Black and Hispanic and white populations. As you can see, hospitalization rates have gone down in all of these race and ethnicity groups. And I will say for within COVID-19, the AIAN population, it can be impacted by fairly specific geography for where our sites are. On the right, these are cumulative rates for this most recent season, which is from October 2022 with data through May of 2023. And as you can see, cumulative rates remain highest among American Indian and Alaska Native populations as well as Black populations. In this most recent season compared to earlier in the pandemic, the gap in hospitalization rates has actually narrowed between Hispanic and white populations. We had previously seen more disparities in earlier years of the pandemic. However, in pediatric age groups, I will note that there still continues to be higher rates among Hispanic children than compared with white children. Next slide. So now I'm going to turn to the data that we have within COVID-19 on COVID-19 associated hospitalizations in pregnant persons. Next slide. So the data I'm sharing here is focusing on since January 2021, so not the very early part of the pandemic. I will note that most pregnant people who are hospitalized with a positive SARS-CoV-2 test had no respiratory symptoms. And this is because in many situations, there's universal screening of women being admitted for labor and delivery or other pregnancy-related reasons. And so we're picking up a lot of asymptomatic or mildly symptomatic women. So I'm going to distinguish here between women who are admitted with respiratory symptoms versus those who had no respiratory symptoms on admission. The proportion who have been admitted with no respiratory symptoms has increased, but generally speaking, overall in this time period, only 21% of pregnant women with a positive SARS-CoV-2 test had respiratory symptoms recorded. The proportion without respiratory symptoms has increased from the sort of pre-Omicron period from 73% up to 82% in the later Omicron period, which is from last July on until now. I will say in the table 1, these are characteristics of the pregnant persons who were admitted with a positive SARS-CoV-2 test and respiratory symptoms. And among symptomatic patients, the proportion with underlying medical conditions has increased over time. And we are also seeing this among the general population. Next slide. This table shows clinical outcomes in pregnant persons over time. And this is, again, limited to only those who are admitted with respiratory symptoms. Generally speaking, in pregnant persons, similar to what was seen in the general population, clinical outcomes have been trending to be somewhat less severe over time, with 4% of pregnant patients with symptoms and a positive SARS-CoV-2 test admitted to the ICU over the last 11 months, compared to 17% in the earlier period. These trends were similar in other outcomes shown on the slide, with statistically significant fewer patients receiving high-flow nasal cannula, oxygen support, or requiring vasopressor support. Next slide. So this slide shows the vaccination status among pregnant women who are hospitalized with a positive SARS-CoV-2 test and stratified by symptom status. Of note, in recent periods when boosters were available, more asymptomatic pregnant patients had received boosters compared with symptomatic patients. But regardless of symptom status, you can see from this slide that most pregnant persons with a positive SARS-CoV-2 test were not up to date with vaccination. The rates of the proportion among hospitalized patients who had received vaccines recently was very low. It was less than 30% for both asymptomatic and symptomatic patients. And note that we didn't show separately the proportion who had received a bivalent booster since the numbers were so small. We only had one hospitalized patient who was pregnant who had received a bivalent booster, which may tell you something about how effective bivalent booster is in keeping you out of the hospital. Next slide. All right, so I'm now going to shift my focus to talk about COVID-19 associated hospitalizations in infants less than 6 months of age, which is a group that we've been watching very closely. Next slide. This is a similar epi curve to what I showed earlier of weekly COVID-19 associated hospitalization rates from the start of the pandemic through until the end of May. The brackets above them show the different periods of SARS-CoV-2 variant dominance. So COVID-19 associated hospitalization rates in the older adult age groups are shown in blue, with 75 and above in the dashed lines, and the dark blue is 65 to 74. In red, the rates are, the red line is rates in infants less than age 6 months. And then rates in older pediatric age groups are shown in gray at the bottom. And they're hard to see because they're significantly lower than those other age groups. I'll focus on those in a moment in a slide. But what you can see here is that rates in young infants less than 6 months of old start off well below those of adults in the pre-Omicron period. But in the Omicron period, rates in young infants are similar to levels seen in adults 65 to 74 years of age. Rates in this age group really increased in the periods of Omicron variant predominance relative to pre-Delta and Delta periods and have remained elevated. They're generally lower now than they were, but they do remain elevated compared to other age groups. Next slide. Before I go into more detail on the data on infants, I did want to talk a little bit about hospitalization rates in other pediatric age groups. I've removed infants less than 6 months of age and adults from this slide to more clearly show the weekly rates in the older pediatric age groups. But please note that the axis on this graph is very different than the one previously. The y-axis only goes to 20 here, whereas it went to 90 on the previous slide. Among pediatric patients 6 months and older, hospitalization rates are highest in those infants and children 6 months through 2 years, shown here in black. The 5 to 11-year age group has generally been the lowest rate throughout the pandemic, although now they're relatively similar to those in 2 to 4 years and 12 to 17 years. All right, next slide. Now, to do a little bit of a deeper dive into infants less than 6 months, we wanted to determine what was driving the increase in hospitalizations in infants less than 6 months. And as you can see here, the proportion of infants who were hospitalized with a positive SARS-CoV-2 test during their birth hospitalization has remained fairly steady throughout the pandemic. It ranges between 10 and 20% of infant hospitalizations in this age group. We did look at whether or not symptoms were recorded for these infants, and the vast majority, or a large majority of these infants were, during their birth hospitalization, shown in blue, were actually did not have respiratory symptoms or COVID symptoms reported. So they may have been picked up on screening or for other reasons. However, next slide. Here we exclude infants who are hospitalized at birth. So this is the remaining majority of infants under 6 months of age who were rehospitalized after being discharged home after birth. And here in blue is the proportion of infants with symptoms, and the gray is the percentage without symptoms recorded in the medical chart. Excluding infants hospitalized at birth, 95% of symptoms had with a separate hospitalization had COVID-19-like symptoms during the Omicron BA.5 period. And the proportion was similar throughout different periods of variant predominance. COVID-like symptoms were nonspecific and could include fever, congestion, cough, shortness of breath, nausea, diarrhea, and lethargy were the most commonly recorded symptoms in this age group. Next slide. This chart shows the proportion of infants less than 6 months of age hospitalized with COVID-19 by severe outcomes, here defined as ICU admission, high-flow nasal cannula, invasive mechanical ventilation, BiPAP, CPAP, and in-hospital death. Again, this slide also excludes birth hospitalization, so only those infants that were rehospitalized after discharge. The colors represent different periods of variant predominance. During the Omicron BA.5 predominant period, so basically since last July onwards, 1 in 5 infants aged less than 6 months were admitted to the ICU, and 1 in 5 were put on high-flow nasal cannula. The proportion of infants with severe outcomes did vary by variant period, with the highest proportions requiring ICU admission and high-flow nasal cannula occurring in that sort of, or mostly ICU admission and invasive mechanical ventilation occurring in the early Omicron period when the Omicron wave first hit. But as you can see, even during this most recent period, the proportion of infants requiring ICU admission and high-flow nasal cannula has remained high at 20% and 19% respectively. Next slide. So in general, hospitalization rates have decreased in all age groups. Over the last year, we've seen a trend towards the extremes of age, with the highest hospitalization rates remaining in those 75 and older, but with infants less than 6 months having comparable hospitalization rates to those 65 to 74 years of age. In pregnant persons, most pregnant persons admitted with a hospitalized who have a positive SARS-CoV-2 test had no symptoms on admission, and they were likely identified through screening on admission. But among those with respiratory symptoms, the proportion with underlying medical conditions has increased, and the proportion with severe outcomes have decreased. Most hospitalized pregnant patients with a positive SARS-CoV-2 test, regardless of symptoms or the reason for testing, were not up to date with their vaccinations. And in infants less than 6 months, hospitalization rates have generally increased relative to other age groups and in general in the Omicron period. Most were hospitalized with COVID-like symptoms, and excluding birth hospitalizations, 20% were admitted to the ICU since June 2022. So thank you very much, and I think I'm now going to be turning it. I would like to thank everyone on the COVID-Net team and many others in Corvid, as well as all of our state and local health partners that help us collect all these data. So thank you.
Thank you so much, Dr. Havers. This presentation is now open for questions. Oh, no. We're going to go straight to the next one. Dr. Galong.
Thank you. Can I get verbal confirmation you can hear me?
Yes, we can hear you.
Thank you so much. Next slide, please. And next slide. So in the following slides, we'll present data regarding what we know about severity of maternal disease, adverse pregnancy outcomes, and then compare outcomes between variant periods. Next slide, please. Regarding burden of disease, cases of COVID-19 in pregnant people were monitored as a part of national case surveillance beginning in 2020 and ending in July of 2022. The figures on this slide show that the rise and fall of case counts of COVID among pregnant people mirrored that of the general population, with peaks as expected during the Delta and Omicron variant periods. By the end of July, over 226,000 cases were reported among pregnant people, along with 738 ICU admissions and 329 deaths. These ICU admissions and deaths peaked as one might expect when Delta was the predominant variant, but as we'll show in subsequent slides, ICU admission and death continued to be observed even during Omicron. When considering these total numbers, it's important to note that the pregnancy variable in this surveillance data was never more than approximately 25% complete among women of reproductive age, so these totals most likely underestimate the true case burden. Next slide, please. CDC's case surveillance data was combined with that of other studies in a living systematic review and meta-analysis that was conducted by Dr. Alati and colleagues from the World Health Organization and the UK. Pregnancy was assessed as a risk factor for severe illness. So among women of reproductive age with COVID, outcomes were compared by pregnancy status. The odds of ICU admission and invasive ventilation were increased in pregnant compared to non-pregnant women of reproductive age. The committee should note that these odds ratios are unadjusted for potential confounders, such as maternal age or underlying health conditions. And according to our epidemiologists, lack of adjustment in this scenario biases toward the null and may underestimate that true risk. We understand from other data sources, such as CDC's Surveillance of Emerging Threats to Mothers and Babies Network, that increasing age, even to the mid and late 20s, and underlying health conditions are risk factors for increased severity of illness among pregnant people as they are for the general population. Next slide, please. These data here are from the same Living Systematic Review and meta-analysis to assess the risk for maternal, fetal, and infant adverse outcomes among pregnant people that's listed on the left. Outcomes are compared here between those with and without COVID-19. All maternal perinatal outcomes assessed were significantly higher in pregnant people with COVID. I'd like to draw your attention to the last column on the far right. The odds of all-cause mortality was 6 times as high for pregnant people with COVID, and ICU admission was 5.4 times as high. There was a 57% increase in the odds of preterm birth and an 81% increase in the odds of stillbirth. Additionally, the odds of neonatal death and admission to a neonatal ICU were more than twice as high for infants born to pregnant people with COVID during pregnancy than to those born without COVID. Of note, these authors are updating the meta-analysis to include outcomes during the Omicron period, but those data are not yet available. Next slide, please. Another way to assess contribution of COVID-19 to pregnancy-related mortality is to take a look at that mortality data for deaths in which COVID was listed as a contributor. Please turn your attention to the figure on the left. Using ICD codes, Drs. Toll and DeClercq analyzed CDC's mortality data, and quarterly maternal mortality ratios were estimated for those with and without COVID-19, shown in dark blue and light blue respectively. The time frame on this figure spans pre-pandemic and through the end of 2021, which we would consider to be as pre-Omicron. The U.S. pregnancy-related mortality ratios rose to a peak of 56.9 per 100,000 live births in Q3 of 2021 and remained high. Our research has shown that racial and ethnic disparities in maternal mortality and pregnancy-associated deaths pre-existed the pandemic, but were exacerbated early in 2020. Turning to the figure on the right, these findings show that these patterns intensified in 2021 with a particularly high pregnancy-related maternal mortality ratio among American Indian and Alaska Native individuals, a group that experienced higher rates of overall COVID-19 mortality in 2021. Next slide, please. Most of what we've shown you so far is based on data from the pre-Omicron period, so now we'll dive into some of that Omicron data. Next slide, please. The data for this figure are provided by colleagues from the National Center for Health Statistics, and NCHS defines maternal death as death of a woman while pregnant or within 42 days of the end of pregnancy. The dark blue bars on this data visualization indicate maternal deaths without a COVID-19 diagnosis, and those with a COVID-19 diagnosis are shown in gray. Death counts that are between 1 and 9 are suppressed in accordance with NCHS confidentiality standards. And so those weeks for COVID-19 death counts are between 1 and 9. They are noted on this figure with black and gray diagonal lines. The variant periods are divided between pre-Delta, Delta, and Omicron predominance, and the shading here that will be used throughout the rest of subsequent slides. We can see here that maternal deaths with a COVID-19 diagnosis began to rise during the pre-Delta period, peaked during Delta when 45% of deaths had a COVID-19 diagnosis code, and then fell to in 2022 during the Omicron period, at which point it was 11% of deaths. Next slide, please. These next few slides show unpublished results of an analysis of hospital discharge data from the Premier Healthcare Database, which is a U.S. hospital-based data set that includes information from over 849 hospitals and health systems that represent approximately 20% of all U.S. inpatient discharges. This figure and the next three show adjusted risk ratios for selected complications, including those that indicate severe illness, comparing delivery hospitalizations with a COVID diagnosis to those without. Please note that the x-axis is on a log 10 scale, and that we've carried that color convention to denote pre-Delta, Delta, and Omicron periods. Reiterated here, of course, is that COVID-19 elevated the risks for acute respiratory distress syndrome and thromboembolic disease among pregnant people. Next slide, please. This was 6.2 times the risk of ARDS and 50% increased risk of thromboembolic disease during the Omicron period, although that was not found to be statistically significant. Next slide, please. This same pattern is carried through to other complications seen on this figure, including for ICU admission, mechanical ventilation, and for death. Next slide, please. And then we will reiterate that although risk is less compared to Delta, that risk persisted during the Omicron period. Next slide. And next slide. Thank you. This pattern persisted in taking a look at specific pregnancy outcomes, including any adverse pregnancy outcome, preterm labor with preterm delivery, and also for stillbirth. Next slide. And we'll note that these risks still remain elevated during the Omicron period. The risk for stillbirth was not found to be statistically significant. Next slide, please. Information on NICU admission, preterm birth, and low birth weight that are shown in this table come from NCHS supplemental reports of presumed or confirmed COVID-19 occurring at any time during pregnancy. And this data comes from 14 states and DC through December of 2022, and it's linked to birth certificate data. The comparisons on this slide, side by side, are made between mothers with COVID-19 and those without COVID-19. Among those without COVID, the frequency of these outcomes appear to be relatively stable between periods, and among those with COVID, these percentages observed increased during pre-Delta and Delta periods. Next slide. So in summary, the incidence of COVID-19 among pregnant people has mirrored that of the general population. Pregnancy has been shown to remain a risk factor for severe maternal illness and adverse pregnancy outcomes, even with new variants. And some maternal, fetal, and infant risks were lower, but still present with Omicron. And in this data, we have not been able to disentangle the impact of prior infection or vaccination on our observations. Next slide. And so in conclusion, vaccination improves outcomes for pregnant people, their pregnancies, and infants. And so vaccination should continue to be recommended for maternal and fetal benefit. Next slide, please. I'd like to thank the contributors to this work, including those listed on the slide. I'll pass next over to Dr. Link Gillis.
Thank you so much. Today I'll be presenting a summary of vaccine effectiveness data available from CDC studies, including vaccine effectiveness by variant period and among pregnant people and immunocompromised people. Next slide. Before diving into VE, I wanted to first highlight current COVID-19 vaccination coverage in the US, shown here by age group. Although most adults have received at least one dose, next slide, a minority of Americans have received a bivalent dose, ranging from less than 8% in young adults to 43% in adults aged 65 years and up. Next slide. Moving on to vaccine effectiveness, or VE, I'll first present updated estimates of bivalent VE by outcome and Omicron subvariant, and I'll then provide an update on monovalent and bivalent VE in pregnant people and bivalent VE in adults with immunocompromising conditions. Next slide. Starting first, I'll present data on VE by outcome and Omicron subvariant in adults from CDC's VISION network. Next slide. The VISION network is a multi-state network based on electronic healthcare records. It uses a test-negative design with cases having COVID-like illness and a positive PCR, and controls having CLI with a negative PCR. Variant periods are designated for analysis based on the time when a novel sublineage became predominant, or more than 50% of sequences in a study site's region. VE is adjusted in this case for age, sex, race and ethnicity, geographic region, and calendar time. Vaccination is determined via electronic healthcare records and state and city registries. Next slide. This slide shows absolute VE of monovalent and bivalent vaccines against hospitalization on the top and critical illness on the bottom, and includes updated estimates from those recently published in CDC's MMWR. Critical illness is defined as admission to the ICU or COVID-19 associated death. Estimates for bivalent VE are shown by time since vaccination at 7 to 59 days, 60 to 119 days, and 120 to 179 days. Note here in the red box the median time since dose, which is nearly identical across the outcomes. Next slide. As you can see, VE of the monovalent dose, shown here in orange with a median of over 13 months from vaccination, is relatively low. Initially, VE of the bivalent dose, shown in magenta, is high. However, waning is evident against hospitalization on the top. Note the different pattern against the most critical illness, shown on the bottom. Although VE drops somewhat, it appears more durable at 52%, a median of almost 5 months after the last dose. Next slide. This slide shows the same information as the previous slide, but now looking specifically at the period of Omicron BA.4/5 sublineage predominance. Note first that the categories are slightly different here at 7 to 89 days and 90+ days, which was done due to timing of the authorization and the end of BA.4/5 predominance. Next slide. Here we see similar patterns for the two endpoints, with maybe a hint of less waning for critical illness, though confidence intervals overlap. Note that we do not split out BQ1 and BQ1.1 here, though previous VE estimates were similar across those sublineages. Next slide. This slide shows the same information as the previous slide, but now looking specifically at the period of Omicron XBB sublineage predominance. First, note the time since vaccination here, which is roughly 1 month longer for the bivalent booster group due to the timing of XBB predominance compared to BA.4/5 predominance. Here again, we see a pattern of waning against hospitalization with VE in the 7 to 89 days since a bivalent booster of 51%, and VE in the 90 to 179 days of 20% with non-overlapping confidence intervals. The trend is different, however, for critical illness, where we see a much smaller decline in the point estimate over time and overlapping confidence intervals. However, note that the CI for 7 to 89 days is 64 points wide due to the timing of vaccine authorization and XBB predominance. Next slide. Next slide. I'll now move on to discuss bivalent VE against hospitalization from the IV network. Next slide. The IV network is a multi-state VE platform that uses a prospective case control design. For this analysis, participants were from 25 hospitals in 20 states with hospitalization between September 8th, 2022 and May 29th, 2023. Participants are adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive PCR or antigen test, and controls are negative for SARS-CoV-2 and influenza by RT-PCR. Vaccination history is ascertained through EMRs, state and local registries, and self-report. Next slide. And here we see monovalent and bivalent VE against hospitalization in adults by time since last bivalent dose. VE of a monovalent dose received a median of 393 days prior to the hospitalization, shown here in orange was 16%. IV data show the same pattern as vision data, with bivalent VE against hospitalization shown in magenta decreasing with time since vaccination, though note that the confidence interval for 120 to 179 days is quite wide. Next slide. Here, VE estimates are broken down into 3 sublineage predominant periods, BA.4/5, BQ.1, and XBB. First, note the time periods for analysis are different for each of the sublineage periods, shown here in the red boxes. For BA.4/5, VE is shown during the 7 to 59 days after the bivalent dose only. For BQ.1, VE is shown for 7 to 59 days and 60 to 119 days. For XBB, VE is shown for 7 to 89 days and 90 to 179 days. Next slide. Next, note the differences in median time since last dose by variant period. Because of the relatively short period of BA.4/5 predominance after authorization of bivalent vaccines, median time since last dose was only 25 days with no ability to assess waning. Median time since last dose was longer during BQ.1 and XBB predominance. Next slide. Overall, VE looks similar during BA.4/5 and BQ1 with lower VE during XBB predominance, similar to what we saw with the vision data. Next slide. All right, shifting gears a little bit, I'll move on to present VE in special populations, starting with pregnant people. Next slide. I previously presented VE methods for the Vision Network, and here we'll share specific methods for the analysis among pregnant people. This analysis focuses on emergency department and urgent care encounters instead of hospitalizations due to sample size limitation, and includes only encounters among pregnant people aged 18 to 45 years. VE is adjusted for the same potential confounders as in the main analysis, with the addition of underlying medical conditions, gestational age, Medicaid status, and site facility urbanicity. Finally, we'll present separate results for monovalent doses received prior to pregnancy and bivalent doses received during pregnancy, which was necessary due to the timing of bivalent dose authorization and the analyses completed for this presentation. Next slide. Here we show results for monovalent doses received prior to pregnancy, split by time before pregnancy, less than 6 months before pregnancy and greater than or equal to 6 months before pregnancy. Although confidence intervals overlap, we see a lower point estimates for doses received 6 months or more before pregnancy, aligning with known patterns of waning in non-pregnant people. Next slide. And here we show VE for a bivalent dose received during pregnancy. The CI is wide, but we see a point estimate of 61% for protection against emergency department and urgent care visits after receipt of a bivalent dose during pregnancy. Next slide. CDC's Overcoming COVID-19 network is another VE network which conducts active enrollment of SARS-CoV-2 positive cases and SARS-CoV-2 negative controls with a focus on children, including infants. This analysis looked at the effectiveness of maternal vaccination against COVID-19 associated hospitalization in infants under 6 months of age. Overcoming COVID operates in 25 pediatric hospitals in 20 states and includes infants admitted between March 2022 and May 2023, so includes both monovalent and bivalent doses. Overcoming includes a parent interview for baseline demographics and clinical characteristics and maternal vaccination status verified through state and local registries and medical records. Next slide. This analysis differs from the vision analysis shown previously. Instead of looking at monovalent vaccine received before pregnancy for outcomes of the pregnant person, this analysis looks at bivalent vaccine received during pregnancy for infant outcomes. Results here are looking at VE against infant hospitalization during the first 0 to 3 months of life on the top and during the first 0 to 6 months of life on the bottom. The analysis did not have statistical power to look at VE separately for 3 to 6 months of age. Note that infants under 3 months of age make up about 2/3 of the infants included in the larger 0 to 6 months of age group. Note that CIs are again wide, but that bivalent doses given to pregnant people helped provide protection against infant hospitalization during both the first 3 and the first 6 months of life. Next slide. Moving on now to updated VE in persons with immunocompromising conditions. Next slide. This slide shows updated data from those published in CDC's MMWR in May from the VISION network. VE is shown for hospitalization on the top and critical illness on the bottom. VE point estimates are generally lower for those with immunocompromising conditions compared to data shown earlier in the presentation for persons without immunocompromising conditions. Waning is not evident in this group, though this may be because of heterogeneity in immune response among those with immunocompromising conditions, or because of limited statistical power to detect differences by time. There were not enough cases to estimate VE specifically for different types of immunocompromising conditions, though VE has been shown to vary based on type of condition previously. Next slide. Moving on now to summary and conclusions. Next slide. The results presented today have several limitations. First, for estimates of absolute vaccine effectiveness, if unvaccinated individuals are meaningfully different than vaccinated individuals, estimates may be biased. For interpretations of estimates of relative vaccine effectiveness, which compare those who received a bivalent dose to those who received only monovalent doses, residual protection from prior doses is an important consideration and likely varies by severity of outcomes studied, making interpretation more complicated. Therefore, since absolute VE is somewhat easier to interpret and conclusions from relative and absolute VE for these analyses were the same, we've shared only absolute estimates today. We have limited information on prior infection, although we know from seroprevalence studies that rates of prior infection in adults and older children were high. VE estimates presented today are therefore a snapshot of how well the vaccine is working under current real-world conditions. VE against COVID-19 associated hospitalizations from the platforms presented today represent individuals hospitalized with COVID-19 disease, but may underestimate protection against more severe disease. Therefore, we've shared estimates for critical illness whenever possible, though often lacked statistical power. Finally, analyses lack statistical power to estimate VE for maternal vaccination by timing of doses during pregnancy. And we could not separate out monovalent and bivalent doses for protection against infant hospitalization. Next slide. In summary, current data from CDC vaccine effectiveness platforms demonstrate that bivalent booster doses help provide protection against hospitalization and critical illness in adults, though we are seeing evidence of waning protection, especially for hospitalization. For most adults, both in the platform shown today and in the general population, more than a year has passed since they received a monovalent COVID-19 vaccine. These individuals may have limited residual protection against hospitalization and should receive a bivalent booster dose. However, results from the vision analysis show more sustained protection against the most critical COVID-19 disease. Data shown today appear to indicate that VE during XBB predominance may wane more quickly against hospitalization compared to earlier variant predominant periods, though this did not appear to be the case for critical illness. Vaccination during pregnancy helped provide protection against hospitalization for infants under 6 months of age, though with some indication that protection may be highest in the first 3 months, which aligns with understanding of timing of waning of maternal antibodies. These findings emphasize the importance for all children receiving COVID-19 vaccination as soon as eligible at 6 months of age. CDC will continue ongoing monitoring of VE, including all outcomes of interest and for all authorized vaccines in the US, with a focus on assessing new policy recommendations in VE in populations at higher risk of severe COVID-19. Next slide. That concludes my presentation, and I want to thank the numerous individuals and teams, both at CDC and at the platform study sites, for their countless hours ensuring high-quality data and analyses are available to ACIP. Thank you.
Thank you very much. I just want to say it takes a village with COVID, because I'm looking to my left and the table is completely full with team members. So I want to thank you for all your work and open up this set of presentations for questions. Dr. Paling.
I want to thank each and every one of you guys for, first of all, a fantastic presentation and sharing the most recent available. And one of the things that we hear commonly stated, which you have disputed, is that children are not impacted by COVID and that it's a benign disease in children. And this data clearly demonstrates that is not the case. And you have beautifully demonstrated that maternal vaccine coverage in children, pregnant persons, and in adults of all ages is protective and beneficial, and bivalent vaccine, or whatever the most recent vaccine we have, is what's needed to maximize protection. And I want to verify my interpretation is correct. Thank you.
Yes, your interpretation is correct.
Grace?
Dr. Long.
It seems as if the protection of infants in the first 3 months of life, unless there was a timing thing about there were different variants going on, it seems as if the mean days since the mother's immunization was 200, and the protection looked like it was 60%. It looks like that's greater than the protection in the mother, or the protection in a non-pregnant person, which wanes to, 20, 40% by that time, 3 months, 6 months. It was 60, 40. I haven't said this very clearly, but since you know the data, you probably understand what my comment is going to be. It looks as if, once again, babies are smart, and they get more antibody than the mother has by ratio. And does that look like that's the benefit?
If you could pull up slide 55, I think we can all look at what you're talking about. I think Yes, this slide. So I think what's important to keep in mind here too is that those confidence intervals are incredibly wide. So I'm not sure I would read so much into the point estimates here differing between infant protection and protection of the pregnant person. But I think what's important is that both of these are showing significant protection for the infant, and then the findings in earlier slides for the pregnant person are also showing significant protection. But I think because of imprecision here, it's hard to really conclude that we're seeing, truly better protection for the infant. But it's clear that vaccination is protecting infants from hospitalization, which is great.
And then the other thing is that the waning of the protection in non-pregnant people as well as pregnant people is very worrisome. And against hospitalization and critical illness looks like 180 days and you're almost out of having any prolonged benefit. So I'm hoping you're about to tell us about what the FDA has suggested as a monovalent booster for hurry up, and hopefully we have some new generation vaccines coming.
So there are a couple of things I think I would keep in mind. First is that I think what we've seen both for monovalent and for bivalent vaccine effectiveness so far is that VE is most sustained against the most critical illness. So IV Network had some really nice results a couple of months ago showing sustained vaccine effectiveness against critical illness, including mechanical ventilation and death for the monovalent vaccine, greater than a year and a half. Compared to lower and quicker waning for hospitalization. And then Vision Network has shown similar findings for the bivalent vaccine. So I think it's important to keep in mind that hospitalization, especially at this point in the pandemic, can mean a lot of things. I don't think we've ever truly solved the for versus with COVID question, and it's likely becoming more of an issue over time. And so I think that critical illness is a really important measure here, and it's reassuring to see that VE is more sustained against critical illness. And then I think I would agree that certainly a more recent dose is better than a less recent dose. But I think everything that we're measuring at this point can be thought of as relative vaccine effectiveness, even what we call absolute vaccine effectiveness when we're comparing to unvaccinated people. Those unvaccinated people probably have had at least one, maybe more COVID-19 episodes. And so everyone at this point, almost everyone in the population has at least an infection or an immunization, or both, often multiple of both. And so we're really looking at an incremental benefit here on top of whatever protection you have from your prior infection. And so I think, sort of across the board, our measurements of VE are lower, but those can really be thought of, there's only so much protection that you can get if you already have remaining protection from a prior infection.
Yeah, and this is Dr. Oliver. I may just make one additional point to follow up on that. One of the reasons that we wanted to show kind of the epi and VE writ large is you really have to look at all of it together. So we do have the waning and the VE estimates that Dr. Link-Gellis showed, but if you think about the hospitalization rates that Dr. Havers showed, we've not seen, as we see kind of some of these relative VE numbers looking lower than the numbers we would like to see, we can kind of zoom out and see that the hospitalization rates for much of this population is remaining low. So it kind of is that you have to look at all of the data points together, which is kind of one of the reasons we ended up kind of clumping the presentation, because it's hard to take kind of a single view. But if you look writ large, the combination of vaccine, and we look forward to updated vaccines, but I think the combination of the vaccines we have and prior infection has meant that hospitalization rates are low currently, which is overall a good thing, and potentially a segue for what Dr. Jones will present next, which is talking a little bit about that hybrid immunity too, but thanks.
And could I ask you to just comment then on the over 85s and their predominance? What kind of a complex story is that about not vaccinated, vaccinated, multiply vaccinated, underlying, won't ever be able to protect them, but it's at a lower level? then what can you say?
I can comment on that a little bit from what we've seen in COVID-19. Among those who are older than 85, obviously they're at pretty much the highest risk of hospitalization and severe outcomes. And this is very consistent with what we see with other respiratory diseases such as influenza and RSV. Among the hospitalized patients who are still hospitalized, many of them are vaccinated at this point, but I think at a certain point with underlying medical conditions and immune senescence in this older age group, vaccines are only going to do so much. It could be that their illness is less severe, but they still meet the threshold for hospitalization. That's why I also think that a really important messaging in this age group is early treatment for patients who have SARS-CoV-2 because they're at high risk for hospitalization, even if they were just recently vaccinated. So I do think that this is where the epidemiology of COVID has really settled out to be very similar to what we see with flu and RSV, with the extremes of age being affected. And I think vaccines are very, very important in that age group, but they're only going to do so much for frail elderly at the extremes of age. Their hospitalization rates, I think, will continue to be the highest on an ongoing basis.
Thank you.
And I will highlight that Dr. Jones does have the kind of milieu of hybrid immunity where it's kind of infection and vaccine. He has some of that broken out by age. And so it is different if you look kind of across the age spectrum. And so maybe we can readdress the question once he's been able to show those data.
I just want to get to the Zoom room. So Dr. Cotton.
Thank you. I just wanted to highlight that immunocompromised adult data and how much improvement we are seeing now. I mean, that's really impressive for critical illness and those, the extent of vaccine efficacy, especially within the first 180 days after bivalent vaccine, and then hospitalization, also quite protective against that. And I think for me, what's sad is the estimated 3% of the US population that is immunocompromised that hasn't had the opportunity to even get a first dose of vaccine, much less a second dose. So I would really, really encourage people who are immunocompromised or who have family members or loved ones to really encourage them to get at least a first dose, hopefully a second dose, and then we will hear more about the upcoming vaccine for this fall, but hopefully an additional dose, because the important part is that immunity wanes over time and we have the capacity to have good protection. So thanks very much to the CDC folks for emphasizing the immunocompromised population as well. Much appreciated.
Thank you, Dr. Cotton. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I just wanted to give a huge thank you to you guys. I mean, this was incredible. The data on pregnant women, it's so heartening. So thank you, thank you, thank you.
Thank you. And we do have to move on to the other two presentations, but I also just wanted to put in a plug because this committee has been thinking a lot about maternal infant protection with the RSV vaccine conversation and just recognizing that we have Tdap, RSV, flu, COVID, that women are pregnant for a certain period of time, helping with guidance around thinking through a pregnancy vaccination platform would be actually really helpful, particularly since 3 of those 4 that I mentioned are actually seasonal. So thank you. We will now move on to, I believe it's Dr. Jefferson Jones, who will be presenting on infection-induced and hybrid immunity.
Thank you and good afternoon. So in response to a request from ACIP, I'll be presenting a fairly short summary on a fairly complex topic, COVID-19 infection-induced and hybrid immunity. Next slide. So first, what type of immunity does the U.S. population have? By following a longitudinal national cohort of over 70,000 blood donors, testing donations for spike and nucleocapsid antibodies, and inquiring about vaccine history once each quarter, we estimated the shift in immunity from the second quarter of 2021 to the third quarter of 2022. So a shrinking proportion of people have no antibodies, as shown in green, while the proportion of those with any antibodies increased to over 96% by the end of quarter 3, 2022. And as shown in blue, the proportion with hybrid immunity reached almost 50% by quarter 3, 2022. Yellow is the proportion with infection-only induced antibodies, and the sum of blue and yellow is the proportion that have been infected at least once. and this reached over 70% by Q3 2022. The proportion of those that have been infected or have hybrid immunity is certainly higher today. Next slide. The prevalences differ significantly by age group. The top left displays data for those aged 16 to 29 years who have the highest prevalence of infection-induced and hybrid immunity, again in yellow and blue. Among this group, hybrid immunity reached approximately 60% by Q3 2022. The bottom right displays data for those aged 65 years and above who have the lowest prevalence of infection-induced and hybrid immunity, with hybrid immunity of just 37% in Q3 2022. These prevalences also differ by geographic region, race, and ethnicity. Next slide. Violin plots of quantitative spike binding antibody titers are shown for the same adult blood donors. As shown on the left, titers by age group were found to be similar. As shown on the right figure, antibody titers by history of vaccination and infection were found to differ. For those previously infected and unvaccinated, or meaning only infected, there was a lower and wider distribution of antibody titers. Next to the right shows those with hybrid immunity who had the highest titers, and furthest on the right shows those who had been vaccinated but without previous infection, only slightly lower than the hybrid immunity group. Next slide. For children, the antibody seroprevalence was estimated using a repeat cross-sectional study on blood specimens collected by commercial laboratories previously shown. Vaccine history is unknown in this study, and shown on the left is the proportion of children who had been infected at least once, as measured by antibodies. This increased throughout 2022 in all age groups, except those aged 6 to 11 months, which stayed at about 60% shown in blue. The next lowest, shown in green, was among children aged 12 to 23 months, reaching 82%. In those aged 2 and above, displayed in the top 3 colors, approximately 90% had been infected by the end of 2022. On the right is the proportion of children with antibodies to either vaccine or infection. Nearly all children aged 5 and above had any antibodies that demonstrate a history of either vaccination or infection. The lowest prevalence was among ages 6 to 11 months at 75%, in part due to the low vaccine rates in younger children. Next slide. So this slide shows quantitative antibody data among specimens with detectable antibodies from the pediatric commercial laboratory study on the right, compared with data previously shown for adults on the left. Both studies use the same quantitative binding antibody assay. Although the vaccine history is unknown for the children in this study, children aged 6 to 23 months were found to have similar antibody levels to those to the adults who have been previously infected but unvaccinated, likely because most of these children had also been infected but unvaccinated. In contrast, adolescents have similar titers to adults who are vaccinated or have hybrid immunity, likely because many of them are vaccinated and many have hybrid immunity. This may indicate that antibody titers depend more on whether a person is vaccinated or has a history of vaccination than age. Next slide. While the national study did not have any data on vaccination history, we are able to look at antibody titers by history of infection and vaccination status among a smaller pediatric cohort study. This slide shows current unpublished data from the ongoing PROTECT cohort. The study used a different assay than the previously displayed national studies just described, and it specifically measured the anti-receptor binding domain antibody, which again reflects a history of either vaccination or infection. In a group of children aged 16 to just over 17 years with various combinations of prior infection and vaccination, a higher cumulative number of infections and vaccinations, which increase as you move to the right of the figure, resulted in higher antibody titers. The lowest titers were associated with a 1 or 2 previous infections or only 1 vaccine dose without infection, and these are shown in the solid white, blue, and gray boxes. And the highest titers were seen in those with hybrid immunity with at least 2 vaccine doses, and these are the checkered boxes on the right. Next slide. This slide displays the same data by age group, with children aged less than 5 years of age, 5 years on the left, 5 to 11 years in the middle, and 12 to 17 years on the right. And there are few specimens available in the youngest age group, but in general, the antibody levels appear roughly similar to the older age groups for groups with similar infection and vaccine history. Next slide. So many additional studies have looked at COVID-19 binding and neutralizing antibodies, mostly in adults. And I will review a few common themes of the accumulating evidence relating to infection-induced and hybrid immunity among the neutralizing antibody studies. So in unvaccinated persons, infection-induced neutralizing antibody titers are generally highest against variants similar to the variant that infected the person. Infection after vaccination may be moderated by imprinting. Neutralizing antibody titers in people with hybrid immunity may wane slower than in people vaccinated without previous infection. Omicron variants demonstrate greater escape from neutralization than the older variants. Hybrid immunity results in higher Omicron neutralizing antibody titers than immunity from previous infection or vaccination alone, including to recent Omicron subvariants. But this may be influenced by the total number of exposures through vaccination or infection. Additional vaccine doses beyond a primary series can also increase Omicron neutralizing antibody titers. The variant someone was infected with and the use of a bivalent vaccine can influence this as well. Next slide. However, the immune system is more than just neutralizing antibodies. A few highlights of the evidence of other components of the immune system include infection-induced and hybrid immunity results in higher IgA titers than vaccine-induced immunity, which can be important for mucosal immunity. Hybrid immunity may result in a higher number of anti-spike memory B cells than vaccination alone, which is important for long-term immunity. And licensed vaccines in the United States target the spike protein. Infection-induced and hybrid immunity can recognize other more conserved viral antigens, such as the nucleocapsid, envelope, or membrane proteins, allowing the immune system to react to these non-neutralizing antigens. So it's important to note that in contrast to neutralizing antibodies, T-cell immunity from both prior infection and vaccination is well preserved against the spike protein of Omicron and subvariants. Even if antibodies are less able to neutralize and prevent SARS-CoV-2 infection, cellular immunity is another important line of defense that is likely important in preventing severe disease. Next slide. So displayed is the WHO-associated systematic review and meta-regression of epidemiologic studies with various types of immune exposures that were conducted when only a monovalent vaccine was available. On the left, it showed that hybrid immunity with the primary series or a booster dose provided the highest level of protection against hospital admission or severe disease from Omicron. At 6 months since last vaccination or infection, protection from hybrid immunity, as shown in the light and dark blue, was approximately 95%, compared with protection from previous infection alone, shown in green at 80%, protection from the first booster vaccine dose alone, shown in red at 77%, and protection from a primary series vaccine alone, shown in the peach color at 65%. Protection from vaccination alone appears to wane quicker than protection from infection or hybrid immunity. On the right, protection against any infection from Omicron is shown, and at 6 months since last vaccination or infection, there was a similar protection conferred by hybrid immunity or previous infection alone, shown in the light and dark blue and green at approximately 50 to 60%, with all three types of immunity conferring greater protection than vaccination alone, shown in the peach and red colors at 15 to 25%. Next slide. So in conclusion, SARS-CoV-2 infection can result in severe disease, death, and long-term morbidity, including long COVID, whereas COVID-19 vaccination is safe and effective at preventing severe COVID-19 disease. The proportion of people with immunity from infection or hybrid immunity has increased over time, but differs by age and other demographic factors. Immunity following vaccination and infection wanes over time, and both primary series vaccination and a history of particularly pre-Omicron infection provided much lower protection during Omicron than during prior COVID-19 waves. Compared with protection from infection or vaccination alone, hybrid immunity likely better protects against infection and severe disease with Omicron. Stronger protection is likely provided when the infecting variant is similar to the circulating variant, but this may be complicated by imprinting. And current protection is likely influenced by both the cumulative number of vaccine doses, the number of times infected, the timing, or how recent the most recent vaccination or infection was, and how closely the circulating variant matches the vaccine or prior infection. And all of these conclusions appear to apply both to children and adults. Next slide. Thank you. I'd like to acknowledge many people from all the studies, much more than are just mentioned on the slide, and many at CDC have contributed to these slides. Thank you.
Thank you very much, Dr. Jones. This presentation is now open for questions. Ms. Bata.
Thank you for this. I feel better now that I did end up with COVID, but I've been vaccinated. There's maybe a little bit of redeeming factor there. I'm trying to understand how this information will help us as we think about subsequent boosting. It looks like there's a fairly sustained protection once someone's been infected and then received the booster. And if the upcoming booster is still of the Omicron strain where we're seeing that circulate, how do we recommend boosting for those who've had that hybrid immunity?
So perhaps I'll start and then let vaccine policy contribute as well. So I think all of this presentation should be taken into account of the previous the previous presentation as well, where we have our high-risk groups that are shown, and despite the high seroprevalence that was seen, we see that particularly for certain risk groups, the prevalence of previous infection is lower. That certain risk groups, their baseline risk is much higher. So even with vaccination or previous infection, their remaining risk may be still considerably high. And that we appear to show that waning protection even against severe disease. The systematic review that was shown, that was studies published up to mid-2022, and there's always a question of new variants and how that will influence things. So I think we have to always pay particular attention to the current epi, which groups are highest risk, and then continue kind of that risk-benefit analysis. There's unfortunately no available test to really, you can't just measure your antibody level and know if you're protected or not. That on an individual level, knowing your protection is quite difficult, so you have to take into account your risk status.
Thanks, and Dr. Oliver, I'm happy to just give a few additional points. I agree with what Dr. Jones said, and just so first acknowledging that yes, we are in a setting where we're now making recommendations, in a setting of high seroprevalence. Kind of initially, when we were making kind of the primary series recommendations, that was in a setting of relatively lower seroprevalence, and so I think this will just be an important consideration as you guys continue to make recommendations for COVID vaccines, and that's why we're trying to bring kind of the totality of the data, but pointing out that over time, antibodies wane, and they can wane after both infection and vaccination. And so overall, it's safer. What you're going to need is a boost to those antibodies. It's safer for that to come from a vaccine than to come from infection, because you have the risks that come with an infection overall as well. But acknowledging that I think vaccine policy, that's one of the reasons that we've seen vaccine policy change, and we made kind of recommendations that differed back in April from what happened in 2020, just because we acknowledge that we're kind of in a different point where many of us have had multiple vaccines, but also potentially have had infection as well. And then, okay.
Thank you. Dr. Cotton?
I wanted to say thank you to Dr. Jones. That was an amazing presentation. Do you know if this type of data will become available for immunocompromised patients?
So national studies, I think, are going to be hard to come by. With the limited amount of time today, we weren't able to do a review of the immunocompromised literature. Happy to, we do have some studies that we can share later, but they are generally much more limited and much smaller in size. But as expected, it depends on the immunocompromised status. The antibody levels do tend to be lower for immunocompromised with a kind of similar vaccine infection history. But it also heavily depends on the condition. Something like a solid organ transplant or bone marrow would influences much more than chronic steroid use per se.
Great. Thank you very much.
Thank you, Dr. Paling.
I too want to add my thanks to all of you guys and to Dr. Jones for this incredible information. And my interpretation is that having protection from vaccine is really important regardless if you've had infection. And that's really important with the data showing that our young children do get COVID vaccine. And because they are relatively young, they may not have had infection. And so the vaccine protection is particularly important for them. Thank you.
Thank you. I've said hybrid immunity is stronger and lasts longer. It rhymes. Okay. Dr. Brooks.
Yeah, that's excellent presentation. I'm glad you also mentioned the B cells and the T cells, because we're always talking about antibody levels, but T cells are there always. Yeah, they don't get the respect they deserve. Can you go back to the last graph, about 3 slides back? Yes. So am I to interpret this as you do better with infection plus the primary series versus infection with the booster? I just wanted to understand why infection plus first booster drops off more rapidly than just primary series.
So the shading in these graphs are the confidence intervals. So if you look at infection plus first booster dose, the confidence intervals overlap quite a bit. So I assume you're looking at the any infection. It gets a little hard because there's a lot of shading kind of overlapping, but there's multiple studies that aren't necessarily the same studies. But I guess overall I'd interpret that with caution, that whether you have a booster dose or primary series, particularly against infection, waning does occur. Beyond that, I don't think this has a strong suggestion.
And just acknowledge, Jefferson, correct me if I'm wrong, but this is zeroing out at time since last vaccination, but we may want to acknowledge that the variants at play may be very different at times. So if you think about when somebody, what variants may have been circulating when you were doing a study on that primary series may have been different in a booster, and so that could also be something that's not really accounted for in the figure.
And that's kind of what I was thinking, that though when you're getting your booster, that means you had a primary series, so it's months out from when you got the primary series. Right.
Thank you, Dr. Lair.
So this slide on the left is probably the one that's given me the most thoughts, because what I'm trying to do is to protect against hospitalization and severe disease, not any infection. And it seems that we've got fairly good protection out for many months if you have hybrid disease. And that makes me think that maybe we don't need boosters as often as I was thinking we might. So thank you for this slide, because it's a very helpful slide.
But I'll add, there are studies so it's difficult to have studies that really know the infection status of everyone for VE studies, right? But studies that have looked at, you have been infected before, does a vaccination on top of that still further decrease the risk of hospitalization, have been kind of published and seem pretty consistent. The same analysis looked at 0 versus 1, 1 versus 2, 2 versus 3 doses, and did show, even on those with hybrid immunity, that the further increased number of vaccine doses you had, the further protected you seem to get. But as mentioned previously, it becomes more incremental at that stage. So agree that it's important to consider.
Thank you. Ms. Arthur?
Thank you. Actually, I had a different question. It was mentioned by Dr. Jones. You mentioned patients with long COVID. Right now going on, a counter program to this meeting is actually a meeting on long COVID at the National Academies. And they actually had a question that maybe the working group could dig into at some point, which is, what is the importance or what's the data around vaccination with the booster doses for those that are suffering from the symptoms of long COVID? I think that would be another thing that would be interesting, because patients with long COVID are going to wonder whether they should get the booster in the fall, and will they be able to know anything, or can we continue to study how it helps with their symptoms or does not? So I wanted to put it here because I think we're looking at the various issues of different kinds of patients over time with having natural infection and also having a booster. And it would be nice to look at that subpopulation as well.
So I could start. I think there's more literature on vaccination preventing long COVID that is accumulating and stronger. There are case reports of vaccination in those that have long COVID that it seems to improve. I think that's harder to study in larger numbers, but something that we're looking at. Happy to have anyone else add.
Dr. Long, last question.
In reference to what Dr. Lair and Dr. Jones' discussion about these graphs, the fact is, all you showed us earlier in protection and duration, we didn't know any of the previous infection or ongoing or repeated infection in any of those people. So this might, and we know that the infection rate is above 75%. So it might only explain what the confidence interval might be, and the people who had infection and vaccination would be on the higher end of protection for maybe a little bit longer. Am I right about that? Because we don't know anything about the infection, previous or ongoing or repeated infection, in all of the early things that we saw about the duration of vaccine efficacy.
Yeah, so I think it's become very difficult to measure prior infection in vaccine effectiveness studies. So if you think about the typical person being hospitalized that's picked up in one of these studies, they may have had half a dozen prior infections that they, did a nasal swab at home and were never reported in their medical record. And so we've done a lot of work in these platforms to look at prior infection, both in the EHR-based platforms and in the platforms that actually have an interview and self-report. And we find very similar numbers of prior infections, which is about 15 to 20% with documented prior infection. We know from the seroprevalence data that that is a huge underestimate. And so I think because of that, we've been very hesitant to try to make conclusions or control for prior infection in our VE studies, because it really needs to be treated as a mostly missing variable. That being said, I think right now, we're in this context of very high seroprevalence across almost all age groups. And so we really have been interpreting the VE as kind of in the context of the current setting with high seroprevalence. So what can a vaccine do at the population level to boost protection beyond existing protection from either prior infection or prior vaccination?
I just thought of a big problem with my thesis, which is you're measuring disease in those vaccinated and unvaccinated, and the unvaccinated have had prior infections too. So it's very complicated.
Yeah, and I think the one thing I would just add to that as you're thinking about the context of this is to be included in one of these studies, you have to have survived your prior infection. So I think, we think a lot about prior infection providing protection against future disease, but that makes a big assumption that you survived that first infection.
I'd also add in the same studies presented, the blood donor study in particular, that there is higher infection-induced seroprevalence in the unvaccinated versus the vaccinated, and that's likely true in the same populations in the VE studies. So one thing to consider for interpretation.
Okay, thank you. We're going to move on to our last presentation of the day. Dr. Megan Wallace will be talking about the summary and workgroup considerations.
Good afternoon. Next slide. I want to start by presenting data on COVID-19 vaccine uptake in the United States. This figure shows the vaccine doses administered over time by age group. As we can see, uptake has fallen with each subsequent dose recommendation, with the highest number of bivalent doses administered to those 65 years and older. Next. Similarly, this slide shows the current COVID-19 vaccine coverage in the United States by age group. While most adolescents and adults have received at least one dose of COVID-19 vaccine, the majority of the population has not received a bivalent dose, with bivalent coverage ranging from 43% in those 65 years and older, down to less than 1% in children under 5. Additionally, the majority of children less than 12 years old remain unvaccinated, having never received a dose of any COVID-19 vaccine. Next. This slide shows the current landscape of the circulating viral lineages in the United States. The left half of the figure shows the weighted estimates of variant proportions based on genomic sequencing results, and the right side of the figure are the now cast model-based estimates. XBB 1.5 is still predicted to be the predominant lineage circulating, but it has been slowly decreasing over the past couple of months. The lineage with the next highest estimate is XBB 1.16, and all the viruses circulating above 1% are XBB lineage viruses. Next slide. The figure on this slide shows the weekly COVID-19 associated hospitalization rates over time by age group from COVIDnet. Here we see that rates remain the highest among those 65 plus, signified by the red line, while the rates in the younger age groups have been more stable over the past year than we saw earlier in the pandemic. Next. Diving into some of the specific populations of interest, we saw data earlier on COVID-19 in pregnant people, which demonstrated that COVID-19 during pregnancy is associated with more severe maternal health outcomes and adverse pregnancy outcomes. The risk of complications has been lower, but still elevated during the Omicron predominant period compared to the pre-Omicron period, which might be due to the impact of prior infection and vaccination. Most hospitalized pregnant persons with a positive SARS-CoV-2 test were not up to date with vaccinations. Next. When considering COVID-19 in infants, COVID-19 associated hospitalization rates in infants ages 0 to 5 months increased in the Omicron period, with hospitalization rates similar to those seen in ages 65 to 75 years. The majority of infants ages 0 to 5 months hospitalized with a positive SARS-CoV-2 test were hospitalized with COVID-19-like symptoms. Vaccination at any point in pregnancy appears to be beneficial to infants during the first 6 months of life. Next. The workgroup noted that pregnancy remains a risk factor for severe maternal disease and adverse pregnancy outcomes, even with new variants. COVID-19 vaccination improves outcomes for pregnant people, their pregnancies, and their infants. Additionally, there is a growing body of evidence that COVID-19 mRNA vaccines are safe during pregnancy, but current uptake of updated COVID-19 vaccine is low among pregnant people. 23% of pregnant people received an updated dose. The workgroup emphasized that pregnant people should receive the recommended COVID-19 vaccine dose for protection of themselves and their infants. The workgroup will continue to review data and evaluate COVID-19 recommendations for pregnant people as needed. Next. Dr. Jones just presented data on infection-induced and hybrid immunity, showing that hybrid immunity likely provides better protection than infection or vaccination alone. This protection is likely influenced by cumulative number of vaccine doses, number of times infected, timing of most recent vaccination or infection, and how closely the circulating variant matches the vaccine or prior infection. Protection can wane over time after both infection and vaccination, though protection appears to be more durable following hospitalization or severe disease. Receipt of an updated vaccine dose can provide additional protection beyond that received by prior doses or infection and restore protection after waning. Next. The workgroup also discussed data-driven ways to simplify our current recommendations in the future. As demonstrated on this slide, our current pediatric recommendations for initial vaccination are complex, with those 6 months to 4 years receiving 2 or 3 doses, those 5 years receiving 1 or 2 doses, and those 6 and up receiving a single dose. Next. To address some of this complexity, the work group discussed if children ages 2 to 4 years continue to need a multi-dose initial series, or could they also move to a single, possibly annual dose like the older population. Next. This slide shows what these possible simplified recommendations could look like in the future, with infants and children ages 6 to 23 months receiving 2 or 3 doses of their initial series, while those 2 years and older would only be recommended for a single dose for their initial vaccination, eliminating much of the current complexity. Next. In addition to this simplifying our current recommendations, there are data to suggest that those 6 to 23 months would benefit most from a multi-dose initial series, with data in 2 to 4-year-olds looking more like what we see in the older children. This slide, which was previously shown by Dr. Havers, shows the weekly COVID-19 associated hospitalization rates for children and adolescents ages 6 months through less than 18 years. We see that most of the age groups presented here, including 2 to 4-year-olds, have similar hospitalization rates. However, those 6 months to less than 2 years have a notably higher hospitalization rate than the other pediatric age groups over the past year. And I'll remind you all that during the COVID-19 presentation at the February ACIP meeting, they showed that more than 80% of COVID-19 associated hospitalizations in the 0 to 4-year-old age group were likely due to COVID. Next. As Dr. Jones presented previously, antibody seroprevalence for children has been estimated using a repeat cross-sectional study on blood specimens collected by commercial laboratories. Shown on the left is the proportion of children who had been infected at least once as measured by antibodies, and on the right is the proportion of children with antibodies to either vaccine or infection. In those aged 2 and above, displayed in the top 3 colors, approximately 90% had been infected by the end of 2022. And when combined, vaccine and infection-induced seroprevalence was even higher. However, those less than 2 years, in particular those 6 to 11 months, were less likely to be seropositive. Next. In summary, when considering if children ages 2 to 4 years continue to need multiple initial doses, or if this age group could transition to a single, possibly annual dose, we reviewed data that demonstrated that children ages 6 to 23 months have higher COVID-19 hospitalization rates, while hospitalization rates among children ages 2 to 4 years are similar to rates in children 5 to 17 years. Children ages 2 years and up are more likely to be seropositive and may have had multiple exposures through either infection or vaccination. However, no randomized clinical trials have compared efficacy or immunogenicity of a single dose versus multiple doses in this young pediatric population in the context of high seroprevalence. Next. The work group emphasized COVID-19 vaccines effectively protect children from hospitalization and severe disease from COVID-19, but uptake of COVID-19 vaccines in children remains low. While we aren't proposing a vote or policy change now, the work group would be supportive of a move toward a recommendation for a single, possibly annual dose in ages 2 to 4 years based on hospitalization rates and rates of seropositivity in this age group in the future. However, the work group did highlight differences in the transition to a single-dose series from a 2-dose series compared to a 3-dose series. Simple recommendations may lead to increased coverage. We will continue to review data and evaluate the COVID-19 vaccine program in the context of evolving epidemiology. Next slide. I also want to note that we are taking steps toward the recommendation of an updated vaccine for the fall. As Dr. Daly mentioned in his introductory remarks, on June 15th, FDA's Vaccines and Related Biological Products Advisory Committee, or VRBPAC, met to discuss fall strain composition. VRBPAC unanimously voted that the vaccine composition be updated to a monovalent COVID-19 vaccine with an XBB lineage of the Omicron variant. Following the meeting, FDA advised manufacturers to develop a vaccine with a monovalent XBB 1.5 composition. We anticipate updated vaccine doses will be broadly available in the fall. Following updated vaccine authorizations, ACIP will review evidence to inform updated recommendations. Next. As we plan for the fall, COVID-19 vaccines and treatments will likely transition to the commercial marketplace. CDC continues to partner closely with state, local, and interagency partners toward continued successful distribution of COVID-19 vaccines and treatments during this time, including clarification of processes for ordering, shipping, and distribution. Guidance for partners will be published this summer prior to the transition to the commercial marketplace. Most Americans will continue to pay nothing out of pocket for the COVID-19 vaccine due to their insurance coverage. However, approximately 25 million underinsured or uninsured adults will lose access to affordable COVID-19 vaccines and treatments if no action were taken. The Bridge Access Program for COVID-19 vaccines and treatments is a public-private partnership which serves as a temporary measure to prevent the loss of under and uninsured adults' access to COVID-19 vaccines and treatments at no cost after commercialization. Next. In summary, as we discussed today and at the April meeting, COVID-19 continues to cause substantial morbidity and mortality across the population, particularly in groups like older adults and persons with immunocompromising conditions. COVID-19 vaccines continue to be the most effective tool we have to prevent serious illness, hospitalization, and death from COVID-19. COVID-19 vaccination is important for pregnant people for the protection of themselves and their infants. Most of the population hasn't received a bivalent vaccine dose. There is ongoing review of data to continue efforts towards simplification, and the work group would be supportive of additional simplification for children ages 2 to 4 years in the future. FDA advised manufacturers to develop vaccines with a monovalent XBB 1.5 composition, and we anticipate the benefits from the updated vaccine prior to possible increases in cases over the winter. ACIP can discuss future vaccine recommendations at upcoming meetings following updated vaccine authorizations. Next. In closing, I want to thank the incredible team responsible for the work presented today. Next. And before we jump into discussion, I want to pass to Dr. Twentyman, who has some brief updates on preparations for the fall.
Thank you so much, Dr. Wallace. Evelyn Twentyman here with the Immunization Services Division. We wanted to add that alongside our many partners in immunization across the U.S., we at CDC continue to really rigorously prepare for the coming transition in COVID-19 vaccine distribution this fall. We are approaching the sunset of the U.S. government COVID-19 vaccine distribution program and the sunrise of distribution of COVID-19 vaccine through standard routine mechanisms which we have used and refined over decades. And throughout this transition, protecting people from COVID-19 remains a key public health priority. Fortunately, in the coming era of commercialization of COVID-19 vaccines, most Americans will continue to pay nothing out of pocket for their COVID-19 vaccines due to their insurance coverage. In terms of those without insurance coverage, children without insurance will have COVID-19 vaccines covered through the Vaccines for Children, or VFC, program. However, 25 million uninsured adults, as mentioned, were also predicted to lose access to affordable vaccines and treatments. For under and uninsured adults who are not able to access COVID-19 vaccines and therapeutics at no cost, the proposed Vaccines for Adults, or VFA, program could serve as a comprehensive long-term solution and has been proposed in fiscal years 2023 and 2024, but has not yet been enacted into law. As a temporary measure to prevent the loss of under and uninsured adults' access to COVID-19 vaccines and treatments at no cost after commercialization, the Bridge Access Program for COVID-19 vaccines and treatments was recently announced in April of 2023. This is a temporary two-component program beginning in fall of 2023 and ending in December 2024. The first component of the program will be implemented through existing public health infrastructure, specifically through state immunization awardees, local health departments, and HRSA-supported health centers. The second component of the program will be implemented through retail pharmacies. We know that the COVID-19 pandemic highlighted and exacerbated longstanding barriers to adult vaccination, including inaccessibility, availability, and confidence. It also demonstrated the importance of a strong adult vaccination program, including funding and support for adult vaccine purchase and adult-specific vaccine infrastructure. And that's what the CDC is pursuing here in preparation to continue protecting people from COVID-19 in the coming fall. Thank you.
Thank you so much, Dr. Twentyman. Ms. Bata, do you have your hand raised? You do, okay. Please go ahead.
Just clarification that from slide 12, that we've got the schedule as 2 doses of bivalent Moderna or 3 doses of Pfizer, and that we would make that current to whatever the current vaccine is, a monovalent or a bivalent.
Yes, that is my understanding.
Dr. Paley?
I want to say thank you to all of you for the presentation. It is very heartwarming to hear about the Bridges program and that there's active work to create a vaccines for adults program and the infrastructure needed for all of these. I wanted to respond and say that I am enthusiastic with the direction that the work group is going in. The hospitalization rate among our children 6 months to 23 months of age reflects that is relatively high and resembles that of older adults. And so maintaining the multiple doses makes a lot of sense to me. And I also respect that with the data we have, I do believe, and the lower hospitalization rate in children over 2, I do think now is a very good time to consider simplifying to a single dose. Thank you.
Thank you. Dr. Talbot?
I just want to keep repeating vaccines for adults. It's going to catch on at some point.
Thank you. Dr. Allaire?
So could someone give me a little more information about the Bridge Access Program and how private practices or FHQCs would get access to that? Is that even set up yet, or is that still in the works?
Yeah, so this is Dr. Oliver, and I'm going to jump in really fast because I just want to say that you've heard Dr. Twentyman's voice as on the COVID work group. While we were devastated to lose her on this, clearly she is doing unbelievably fantastic work helping get the Bridge program set up and established. So we'll toss to her, and obviously we're in excellent hands with Dr. Wallace as well as the co-lead. So I just wanted to kind of acknowledge that transition that we'll miss Evelyn, but clearly she's doing fantastic work over there. So anyway, that's my way to toss to you, Evelyn.
Thank you so much, Sarah. That was incredibly kind. And thanks for the question, Dr. Lair. This program is actively being set up right now. There are 2 components, and I'll dive into them a little bit more since you asked the question. So I mentioned the first is through existing public health infrastructure. So awardees, in other words, our vaccine awardees, will support and coordinate with their existing adult immunization programs. Those include their local health departments and their HRSA-supported health centers to get vaccines to under and uninsured adults. And in this case, underinsured, in case anyone's wondering what that means without insurance coverage of cost-free access to vaccine. And then HRSA will also be supporting delivery of vaccines and treatments directly to their health centers, their FQHCs, federally qualified health centers. And CDC will use its authority under Section 317 of the Public Health Service Act to purchase and distribute COVID-19 vaccines and allocate operational funds to awardees. And then there's a second component that I mentioned of the program, which will be implemented through retail pharmacies. So the pharmacy component in terms of vaccine will rely on donated vaccines from manufacturers, and administration costs will be covered by the federal government. Pharmacies included in the program will be among those that have previously participated in federal partnerships during the public health emergency and have the infrastructure in place already to administer COVID-19 vaccines. And that selection and competition process is ongoing. Closing gaps in COVID-19 vaccine access is a program priority here. And so I wanted to specifically call out that participating pharmacies will be eligible for additional payments to establish sites in areas with low rates of access or vaccination. I hope that helped as a brief overview of components.
That's wonderful. Wonderful, thank you. Dr. Sanchez?
Thank you, and really thank you for all that data, for all the presentations. They really were excellent. I think that a few comments, and then a question. you know, we've talked yesterday a lot about the timing of maternal vaccination and with the potential for RSV vaccination. And really, I think with COVID vaccine, it really is important to give it to the mother early because we are actually needing to prevent her more severe disease. So I think that's one thing. And I think the other thing that's really important in terms of the infants less than 6 months is a slide that really showed the degree of respiratory support in ICU admissions that were needed. I mean, these were not just benign hospitalizations in many instances, and the deaths were not zero either. So I think that that's really important. Now, my question is, as the FDA has mentioned to these companies to go to a monovalent variant, a new Omicron variant, how is that going to affect pediatric vaccination? Does this apply? Are they making a pediatric vaccine different? So is the new version of the
Do you mean the updated COVID-19 vaccine that we all hope and will come along this fall?
Yeah, so this is Dr. Oliver. I'm happy to take a stab, and then if anyone from FDA wants to make additional comments. But I will note that ACIP and VRBPAC had weighed in previously on the harmonization of kind of primary series as well, and simplifying to a single composition. And so we anticipate moving forward that as we update the composition, kind of the entire program would move. We wouldn't kind of do this piecemeal by age. But Dr. Caslow, if you wanted to say anything else.
That's correct. That's the intent, is to harmonize for all doses, all ages, same composition. So in the fall, that would be the 2023-2024 formula would be an XBB.1.5.
So when we're looking here at 2 doses bivalent Moderna, 3 doses bivalent Pfizer, I mean, it's going to be monovalent?
Yes, across the board.
Across the board will be a pediatric monovalent dosage for across the board there?
That is the intent.
Okay, thank you.
Thank you. And I just wanted to put in a small plea for the immunocompromised pediatric population, just to make sure that there's appropriate dosing and preparation and guidance for that. I have one more question in the chat. Dr. Goldman?
Thank you, Dr. Lee. First, a thank you to the team. Incredible presentation. Always so appreciative of the work. And then a small plea. From the beginning of the pandemic, small independent private practice has not had access universally to be able to give vaccines to our patients. And following up on Dr. Lair's question, I would hope that we can include small independent private practice as a necessary part of the infrastructure of care delivery to our patients, and find a way to not only support and sustain private practice, but be able to allow us to give the vaccines. And while the retail pharmacies are extremely important and have been important, we should not be discounting the ability of the private practice to be able to support our patients. So I would hope that in the Bridges program, we can find a way to include the small practice in that, as well as a vaccine for adults program, which is critical to be able to make sure we have access for our patients. Thank you.
Thank you, Dr. Goldman. And Dr. Daly gets the last word.
Yeah, just a couple quick words. First, I want to thank the FDA for the partnership on all this. I mean, we may have different roles, but we have similar goals. And so I think we're really getting to a good place. I'd also acknowledge that it takes a little time for any of our immunization program, and I mentioned this yesterday in a different context, but sort of any of our immunization programs to settle on a place that we think is the most effective strategy moving forward. And then we always adjust as we need. And it feels like we're moving to a place where likely a single annual booster for most people, maybe not for everyone, that is the most updated, is where we're moving towards. And then I think we steer all of our immunization services delivery to achieve as high a coverage as we can in those groups. So we're working towards that, and we'll continue to work towards that. And then finally, just want to thank the team. You guys did a fabulous job, as always. Thank you so much.
Well, thank you all again. Thank you to our speakers. Thank you to our ACIP members, our ex officio members, and our liaison members for being present and very engaged over the last 3 days of our ACIP meeting. I also just wanted to take a moment to express my personal gratitude to the CDC for allowing me to serve in this role for the past 7 years. I now have a daughter in college. So I'm humbled and grateful for the opportunity and really appreciate it. Any business, any objections to closing today's meeting?
Dr. Lee, I believe we've completed our work.
Wonderful. Thank you, everyone. And I am happy to adjourn today's ACIP meeting.